Hello all. In today's episode, I am excited to host Dr. Anupam Sibal. Dr. Anupam Sibal is Group Medical Director at Apollo Hospital Group. He is Senior Consultant Pediatric Gastroenterologist and Hepatologist. He has been President Global Association of Physicians of Indian origin from 2020 to 2022. His achievements and contributions are countless. Just to name a few, he helped set up the first successful liver transplant program in India in 1998 at Apollo hospitals. And by the way, this remains the busiest solid organ transplant program in the world since 2012. Another important milestone, 551 pediatric liver transplants, 151 publications, 16 chapters, more than 400 national and international lectures. And to top it all, he is also an author of national bestseller, Is Your Child Ready to Face the World? Welcome, Dr. Anupam Sibal.
Thank you very much, Dr.J.S.Tuteja. It's indeed an honor for me to be a part of your talk show, and the amazing work that you have done over the years has brought all of us together and made such impressive contributions. Namaste. I'm going to start my presentation. So what I'm going to be doing is really talk about 25 years of pediatric liver transplantation in India, how the outcomes have improved, and how we've been able to enhance access for all. So over the years, the indications have improved. Transplants are now performed in children where there is chronic liver failure, there is acute liver failure, where there are hepatic malignancies, hepatoblastoma, HCC, metabolic disorders that produce liver failure, and also inborn errors of metabolism where there is no liver failure, but providing a new liver prevents the extrahepatic complications of that underlying condition. So metabolic conditions leading to liver failure where a transplant is performed. Wilson's disease is the commonest for us in India. Tyrosinemia, type 1, glycogen storage disease, certain types, galactosemia. Metabolic conditions in which there is no liver failure. Crigler-Najjar syndrome where carnicterus is prevented. Primary hyperoxaluria where kidney failure is prevented. Repeated admissions to ICUs are prevented in organic acidemias, urea cycle defects, development which can get compromised, that developmental delays can be prevented by timely liver transplants. When should one talk about doing a liver transplant? Where there are clear pointers. Failed Kasai, and the definition is that if the bilirubin is more than 6, 3 months after a Kasai, then a liver transplant should be offered. Initially, several years ago, we used to wait for 6 months, but now it's very clear. A baby with biliary atresia has a Kasai's portoenterostomy. 3 months after the operation, if the bilirubin is more than 6, this child's going to need a liver transplant. Recurrent cholangitis, which is quite common, repeated episodes of fever and an infection, portal hypertensive bleeding. If the synthetic function is compromised, which manifests itself by a decrease in albumin or prolongation of the prothrombin time. Intractable pruritus, which itself is a very, very big problem in progressive familial intrahepatic cholestasis. That in itself becomes an indication because the quality of life is so compromised. Malnutrition, which is not responsive to intensive nutrition therapy, and in acute liver failure, if the INR is more than 4, then that is a pointer for need for a liver transplant. Now, the liver has 8 segments. Each of these has its own blood supply, own venous drainage, own biliary drainage. So it's possible to remove segment 2, 3, and 4, which is the left lobe, or segment 2 and 3 of the left lobe, or just segment 3. It's possible to remove the right lobe, and with these different options available depending on the size of the baby and the size of the liver of the donor, the operation is planned. So we use the right lobe in adolescents, older children, the left lobe in children, left lateral lobe in smaller children, and monosegment in the newborn age group. And what we look at is we look at the graft ratio and compare that with the weight of the recipient and we want this GRWR to be between 1 and 3%. Cadaver organs don't become available easily because there's a huge waiting list for adults. So if an organ becomes available, it'll go to an adult, but sometimes we can actually split the liver, and the right lobe can go to an adult and the left lobe can go to a child. And there we look at the donor to recipient body weight ratio. And if it's between 2 and 12, the graft is considered for splitting. ABO incompatible liver transplants now are performed commonly. They're very successful in young children. We use plasmapheresis, we use rituximab. And in families where there is no blood compatible donor, incompatible transplants can be offered. We also have the ability to do swap, where the donor from one family donates a part of his or her liver to a recipient in another family. Of course, all these 4 operations need to happen simultaneously. We can also do domino transplants, and in this case, there is a metabolic condition in the donor. We can remove the liver and pass it on to someone with liver failure, and this is possible, say for example, in conditions like MSUD. Now, how successful is liver transplantation? Now, this is data which was published about 10 years ago, 20-year survival rate, and if you notice, overall 80%. Now, these were transplants performed in the 90s. Now, if we look at transplants that are performed in 2000, and when that data becomes available, clearly the outcomes, the survival at 20 years is going to be more than 80%. So if we look at data from Europe, 5-year survivals, which used to be 74%, became 83%, and now 85% since 2010. If we look at the data from Korea, quite impressive, from 81.5% survival now to 98.6% survival. So when we started talking about liver transplantation in 97, there were 3 questions that were asked of us. Is there a need? If there is a need, then why can't we send these children abroad? Why do we have to set up a program in India? And is it even possible? A paper around that time had shown that 30% of children presenting with liver disorders needed a liver failure, needed a liver transplant for either acute liver failure or chronic liver failure. And if we look at the Western data of at least 1, if not 2 pediatric liver transplants that need to be performed per million population, at least 1,200 pediatric liver transplants would be needed. So clearly there was a need. Well, we could send them abroad, but then the cost at that point in time was between 2.25 crores to 90 lakhs, which has of course since increased. There's this additional cost of travel, stay, and then the waiting period is very long. And to get a cadaver, a foreigner is usually the last priority. So sometimes organs which aren't ideal will be the only organs that would be offered. So clearly there was a need, and we needed to start talking about developing a liver transplant program in India. But then, with our economic situation, what it was at that point in time, and all the other challenges that we had, with children dying of malnutrition and dehydration and pneumonia, was it even appropriate to think about a liver transplant program? But by that count, then we should never have ventured into space technology. And we've all seen the benefits of space technology in different facets of life. So we decided that we will move ahead with the liver transplant program, but will not seek any governmental aid or resources. Well, would it be possible? Yes, there were lots of questions about it. And of course, we also had many concerns on whether we'll be able to pull it off or not. There were other questions that were asked. Will parents donate? Will infections be lethal? There was so much of tuberculosis. What about the bias against the girl child? All of us as pediatricians and neonatologists know that the ratio of boys versus girls when it comes to whether it's pediatric urology or pediatric cardiac surgery, boys outnumber girls. So wouldn't there be a bias against the girl child when we talked about a transplant? And won't liver transplant only for the rich because it's such an expensive undertaking? So we attempted the first pediatric liver transplant in January 1998. This was from a nurse whose family had agreed to donate her liver. Unfortunately, we developed graft non-function and the baby died. We waited for several months, and because no organ was becoming available, we decided that we will have to develop a living-related liver transplant program. And the first such transplant operation was performed on 15 November 1998 at Apollo Hospital, Delhi. We waited for 2 years and then published this as a case report. A year later, we published the first case report of successful liver transplant for acute liver failure due to hepatitis A. But the first decade was really tough. There was very little faith that the community had in liver transplantation, as a result of which very few families came forward and patients got referred to us at a very late stage when they had a few days or weeks to survive. As a result of which, in a very long period of a decade, only 95 children were fit for a transplant, of which only 40 families were willing because the others felt that it wasn't really worth the risk. And we were able to transplant only 16 children in 10 years. And during the same interval, we could transplant 88 adults. There were just so many roadblocks that we met. And it really was like banging your head against the wall. But finally, the wall broke. And the watershed for us came in 2007. This initial cohort of 100 plus patients had gone out into the community, were leading a normal life. So the confidence in the community at large increased. Also, the medical community felt that it was a worthwhile undertaking. So we started getting patients earlier when they were fitter. So we had the opportunity of assessing 590 children, and we had performed 538 pediatric liver transplants in this intervening period, and 3,952 adults. What has contributed to success? Well, clearly better surgical expertise. When a surgeon has done 500 and then 1,000 and then 1,500 transplants, clearly the outcomes are better. Improvements in intensive care and, of course, standardized post-transplant care. Better technology, and here you can see 3D reconstruction of the hepatic venous anatomy of the donor liver to help the dissection. 3 Tesla MRI showing the biliary drainage to help decide where to resect, and the use of CUSA to decrease or minimize bleeding. Then we've done some innovations, like we use the portal pedicle to decide where exactly to do the dissection so that the piece of the liver that we remove fits in very well into the small belly of the baby. Also, to prevent portal vein thrombosis, which is a problem, we put in an intra-op stent to prevent the chance of clotting. Over the years, with the success, the scope has advanced, and we are now able to transplant children who we wouldn't have earlier taken on. For example, this child Amal from Qatar, she has Crigler-Najjar syndrome. You can see she's under a physiotherapy unit, and despite 18 hours of phototherapy every day, she had a bilirubin of about 20. So we transplanted her. This is her yellow background, white eyes after a successful liver transplant. She became the first child to be transplanted for Crigler-Najjar syndrome in India, and also the first child where a liver transplant was offered where there was no liver failure. We've now transplanted 6 children with Crigler-Najjar syndrome, and this boy wanted, of course, to meet his hero Salman Khan, and he obliged. This is a child with maple syrup urine disease, and this is him just after transplant when he started to sit up, and this is him a few years later. This child came to us from Sudan with renal failure for a kidney transplant. But when we investigated, we discovered that this child actually had hyperoxaluria, and just doing a kidney transplant would not help because the new kidney would also get damaged with oxalate. So we decided to offer a combined liver kidney transplant. Luckily for him, he had twin sisters. One sister donated the right lobe, the other one kidney. And this is this child that discharged after a combined liver kidney transplant. This is the smallest baby we transplanted. She was not 4 kilos at that point in time. This is her at discharge, and this is her 4 years later. And then, of course, we've had some very, very challenging cases where we thought whether we should or we shouldn't transplant, like baby RC. You can see her belly, hugely distended ascites, and severely malnourished, extremely high risk. But we decided that we would take on her case, and this is her a few months later, and this is her 5 years later, leading an absolutely normal life. Sometimes a retransplant is needed, as in the case of this child who initially had a transplant in Saudi Arabia. She's from Syria but lives in the UAE. She got referred from there, and this is her after her second transplant. Mahatma Gandhi had said a man can never be a woman's equal in the spirit of selfless service with which nature has endowed her. And we saw that. It was only mothers who came forward or grandmothers who came forward to donate. And in the first decade, more than 70% of the donors were female. But we are very happy now that we've got fathers catching up, and now it's about 50% of the donors, father, 50% or mothers or grandmothers or grandfathers. There was a clear bias against the girl child. Initially, 72% of the patients we transplanted were boys. But again, stellar progress here. It's now 51.7% boys and 48.3% girls. And we are hoping that girls will overtake boys soon. Most of the transplants that are performed in India, of course, are living related. Very few cadaver donors, because they end up going to adults, and only 7% of all the transplants that have been performed in the pediatric age group are cadaver. We have the distinction of being the busiest solid organ transplant program since 2012, when we overtook Mayo Hospital, Mayo Clinic, by performing 1,200. Last year, we performed 1,718 solid organ transplants: livers, kidneys, combined liver, kidneys, heart, and lung combined, pancreas, intestine. And this year, till August, we had performed more than 1,100 solid organ transplants. We have now performed more than 4,500 transplants, of which 554 are pediatric. Commonest indication, more than half, biliary atresia, then metabolic, cryptogenic, acute liver failure, cystic diseases, PFIC, Budd-Chiari, autoimmune hepatitis, some poisonings, hepatoblastoma, HCC, hyperoxaluria, which is combined liver kidney, portal vein thrombosis. How successful is liver transplantation in India? And this is data from our program. When we published our initial data with all babies less than 7.5 kilos, we actually had 100% survival. We published the first 100 transplants, our experience with biliary atresia, and it was all up in the high 80s. We then looked at our 5-year survival, and it's now 95.5%. There has been an opportunity for us to publish several editorials. The first one on liver transplantation in Indian pediatrics, only one liver transplant had been performed. When 9 years later we published, 29 transplants had been performed in children in India, of which 13 were at Apollo. When we wrote another editorial, which was 7 years later, 350 pediatric liver transplants had been performed, and then the editorial in 22 years, we had reached the landmark of 150 pediatric liver transplants in India, 90% survival, and ABO incompatible liver transplants were being performed. Now, I want to turn again to space technology. India has the distinction of having launched satellites for 35 countries. We have the ability to launch more than 100 satellites in a single mission. We also have the ability to bring down a satellite should the need arise. If we look at innovation, many of us saw the film Gravity. It cost $100 million to make. But our Mars orbiter mission, which was the first mission to reach the orbit of Mars in its maiden attempt, cost only $74 million. A year later, a film was made, Interstellar, which cost $165 million. But the Chandrayaan mission cost only $75 million. So we understand frugal innovation. When a country chooses a partner in space technology, they look at 3 factors: expertise, technology, and cost. When a country or a family chooses which hospital or which country to go to, they look at expertise, they look at technology, they look at cost. And because of excellent expertise, availability of the best technology, and very competitive cost, we have become a preferred destination for liver transplantation from across the globe. We, for example, at Apollo have performed transplants in patients from 50 countries. This included more than 500 liver transplants in just patients from Pakistan. Recently, we celebrated 150 liver transplants in children from Philippines, and we had a huge celebration there. But I want to spend the last few minutes of my presentation really talking about something that always bothered us. Will liver transplantation only be for the rich? How is it that we could reach out to those with limited resources? Now, we all know that we live in 2 Indias. We have an India where families can go to Disney World several times a year for holidays. And then we have families where meeting the bare essentials for survival is hard. We have children who celebrate birthdays, and we have children for whom 2 square meals a day is a challenge. So we reached out to temples, to mosques for zakat, churches, gurudwaras, charities, crowdfunding. This concept of pay it forward, where someone who's benefited would help others, and reached out to individual donors to raise money. And this worked well for us. This child came to us from Bandipora in Kashmir, a border area, and the family didn't even have money for her to come in a bus. So she came at the back of a vegetable truck. You can see she's got ascites and very sick. So we started raising money through crowdfunding. We were able to raise enough money, not just for her transplant, but also enough money so that her family could get a pakka house in her village, something that they did not have. And this is what she looks like now. But then we discovered that there was a lot of competition for a crowdfunding. So from heart disease, for cancer, and so on. And we believed that this was not sustainable. So we started looking out for people who believed in what Saint Francis of Assisi had said, for it is in giving that we receive. And we found that there are so many generous people. We now have people who give us 5 lakhs, 10 lakhs on one phone call. In fact, they tell us at the start of the year, they're putting aside 25 lakhs or 50 lakhs for the year for pediatric liver transplant. And all we have to do is make a phone call and the money gets transferred to us. So with that, we were then able to offer hope to those with no hope. In the last 5 years, we have raised 24 crores through charity for pediatric liver transplantation. And I want to give you 2 examples. Anishka, 8-year-old girl from Bihar, known case of Wilson's on chelation. Liver transplant was advised. Father worked in a factory. Sole earning member. Condition deteriorated. Plasma exchange were performed in AIMS, and the child was referred to us. Now, this child came to us on 25th March 2022 at 6 p.m. She was critical, had hepatic encephalopathy grade 3. And any child with Wilson's disease who has encephalopathy will not survive with a liver transplant because chelation obviously was not working. We immediately ventilated her, supported her with CRRT plasmapheresis. Unfortunately, there was no compatible blood group donor. So we decided to do an emergency APO incompatible liver transplant with mother as a donor. The family, as I mentioned, had no money, but that's where our families who support us helped. We were able to raise 16 lakhs in 8 hours. We completed the donor workup. We started the liver transplant 31 hours after presentation. And remember that there is no ABO compatible blood donor and the family has no money and the child's on a ventilator. So we started liver transplant at 1 a.m. on Sunday, which was completed at 2 p.m. The child was extubated 43 hours after transplant, 87 hours after presentation to us, and discharged on day 17. This is her immediately at presentation. This is her recovering, and this is her at discharge. Rajdeep Mandal from Calcutta developed jaundice when he was an infant. Because the jaundice worsened, he was referred to us. We made the diagnosis of allergy. At age 8, he developed liver failure. In the meantime, the family was finding it very hard. The mother could not cope and she left. So this child just had his father and his uncle to look after him. Rajiv's father said he'll donate, but he was not suitable as a donor because he had underlying kidney disease. And of course, the family had no money. The condition of this child continued to worsen. You can see the distended belly. He's malnourished. And there was just no living related donor available. And we were getting increasingly worried about this child. A 13-year-old boy from Haridwar presented to us on 16th November. And this child had over a dinner discussion with his aunt, told her that aren't people who donate organs after death amazing? A few days later, he had a fall from the roof of his house and was brought to us, and he was declared brain dead. The family decided to donate this child's organs. So we got Rajdeep onto a flight at 11:45 p.m. from Kolkata. The next day at 2 p.m., he was transplanted. This is him in the ICU. This is him a week later. This is him at discharge. Now, here again, the family had zero money, zero resources. So we now have a situation where we have changed the whole requirement for money. The standard liver transplants, 13.5 lakhs, 15 lakhs for high risk. Those with limited resources, it's done in 6 lakhs. But then we also have a very large chunk of patients where they have no money. So if they have a BPL card and they have no resources, without spending any money, we will be able to offer a liver transplant to them. And we've done many liver transplants in children with very disadvantaged social circumstances, parents where the father works as a daily wage laborer in Jharkhand, someone who sells churis on a cart from Bihar, from UP. We've had individuals who work as personal security guards, and people with very limited resources. And all this has been made possible because India has changed. If we look back when we've transplanted for the first time, India was very different. 2 million cell phones, just 4 airlines, $29 billion in foreign exchange reserves. Now look at 1.1 billion cell phones, 39 airlines, $636 billion in foreign exchange reserves. We are the third largest economy in terms of purchasing power parity. We will become soon the fourth largest economy in terms of nominal GDP. So if India had not got the kind of economic boost that we are seeing, our program would not have been able to offer transplants to children with no resources. This is Sanjay, the first child we transplanted. He came to us from Kanchipuram in Tamil Nadu. Biliary atresia, failed Kasai. This is him at about 20 months of age, severely malnourished, deeply jaundiced. And he underwent a transplant, and it was the first time we were doing this living-related liver transplant. Very stormy course. Was on a ventilator for 7 weeks, had PN for 8 weeks, finally got discharged at 100 days. This is him at discharge with his father, his donor. This is him at the All India Transplant Games with Mr. Chandrababu Naidu. A year later, this is him 4 years later, 7 years later, 9 years later, 12 years later, 15 years later on the cover of the Week magazine. That's when a postage stamp was issued by the government of India, and that has Apollo Hospital. Sanjay decided to pursue medicine and became a doctor. This is him with Mrs. Dimple Kavadia on the 25th anniversary of liver transplantation, and Sanjay got married earlier this year. So if a baby was born with biliary atresia in the 1950s, there was 0% chance of survival. Thanks to Kasai's potoenterostomy in the 1990s, there was 20% chance of survival. Today, if a baby is born with biliary atresia, there is a 95% chance of long-term survival, from 0% to 95%. But more than the numbers, what has given us the greatest satisfaction is that we have removed money from the equation. And we have constantly reminded ourselves of what Gandhiji had said. Whenever you're in doubt or when the self becomes too much, recall the face of the poorest and the weakest man, woman whom you may have seen, and ask yourself if the step you contemplate is going to be of any use to him or her. We have now reached a stage where any family that has a child with liver failure will be offered a liver transplant as long as they have a donor within the family. What they have in terms of resources is irrelevant. Thank you very much.
Anupamji, this is a very elaborate and very informative. You have practically covered everything. What is your advice a family who comes to you for the first time in first visit, so that they are convinced the procedure which you are going to perform in the patient?
So when we get a child, who's developed liver failure and the family comes to us, the first thing we do is actually sit them down and have a detailed discussion with them. See, they're very distraught. They have been told their child needs a liver transplant, and without a liver transplant, this child will die. They have lots of concerns, lots of worries. There are so many questions that bother them. Will this be successful? Who will donate the liver? What will happen long term? If it's a girl child, will she be able to go through puberty normally? Will she be able to get married? Will fertility be a challenge? How will we manage immunosuppression? How will we manage vaccination? How will they deal with common problems in school? And that very important question about money. So we first tell them is that, do not lose hope. You are not the first child, and we've now transplanted hundreds of children. Would you like to meet someone from your kind of, background in terms of education, or from your own state? Same weight of the child, we organize that. We talk to them at length about what a transplant operation is. The surgeon explains in great detail the procedure. We organize whatever we can to sort of make their journey comfortable in terms of when they have to come back to Delhi, because so many of them come from outside Delhi. Where will they stay? How will we manage the post-operative? who will be the doctor who look after them back in their hometown. And then we come to this big aspect of money. And depending on if they have insurance or they have ability to pay, they can pay whatever they can, rest of the money is raised. But the main thing that we tell them is don't lose hope. We are there, and we are privileged to have been given this opportunity to be of assistance.
Definitely, your devotion and dedication raises the limelight for the parents and family, and they are encouraged by your counseling session which you are taking in the first meeting. Anupamji, are there any complication of liver transplant?
See,
Have you come across?
liver transplant is an extremely complicated procedure. There's the risk of sepsis immediately, and then for days to weeks after, there is the risk of a surgical complication like a perforation or clotting of the portal vein or the hepatic artery, or a leak from the bile duct which produces infection. And there is the risk of the liver not working at all. Over a period of time, there is a risk of other viral infections, CMV, EBV. There's a risk of developing post-transplant lymphoproliferative disease. There is a risk of kidney dysfunction because of the immunosuppression we use. So metabolic syndrome, because the sugars can go all over. So there are lots of challenges that one has to face, and therefore, it's a commitment for life, and that the team has to work very, very closely with the team or the pediatrician looking after the child in their hometown, and the medical, the surgical, intensive care, physiotherapists, dietitians, all working together. But we are really happy now that our survival figures are 95%, but still there is a chance of 5% of the children not making it, and that's something that we explain in great detail to the family.
Who should be the best donor in liver transplant? Although you have explained about mothers who are more donating, and now the fathers are also coming up for donation. It may be really difficult to convince the parents about the future with the liver transplant, because the person who is also donating may be little scared of donating here.
Absolutely. I think there are lots of concerns the person who's donating has. How much of the liver will be taken? When will I get discharged? Then we explain that the liver comes in 8 segments. That it has the ability to regrow, and the liver, normally 90% of what has been removed would have regrown in about 12 weeks. The donor typically gets discharged on day 7. In 3 weeks, they get back to a normal kind of routine, and in 3 months, absolutely normal. Fortunately, in our hands, in our program, we've not had any donor serious complications, but donor deaths have been reported in India. Pain is a big issue that obviously the donor worries about. In terms of who's the best donor, we want someone less than 55 who's healthy, who does not have diabetes, renal dysfunction, or any other problem. And we prefer a parent, but we also will take a liver from a grandparent, or can also, if there is an older sibling. So that's really the mix. If there is no one in the family that has a compatible ABO compatible, blood group, then we will go for an ABO incompatible.
Although you have narrated about the cost of liver transplant in India, and I really appreciate that a charitable fund you have raised from different societies and all our spiritual places also. But even then, I think the cost is still quite high, and the minimum is 6 lakhs, as you have narrated in your one of the slides. So, what else could be done for these poor children?
So for our program, it's not 6 lakhs. It's 6 lakhs if someone has some money. If they don't have 6 lakhs, then they don't need to pay anything. As long as they have a BPL card and a donor. We have had patients that we've transplanted where the family spent 50,000 rupees living in a dharamshala after the transplant. And they've not spent any money. So for us, money is not relevant anymore, because we've managed to crack that, which to our mind was the biggest problem. And that was the biggest challenge, because many of these diseases actually are more common in children in the lower strata from a socioeconomic point of view. Biliary atresia, for example, which is the commonest indication, is seen more in the economically disadvantaged. So if we had not cracked money, then we would not be able to offer hope to so many children.
Anupam, the last question from my side, because I'm doing adolescent work also. If a child comes of adolescent age, what should be the best organ adaptability of the as per age?
So again, I think the principles that we use in terms of immunosuppression and all will be the same. We will want a blood group compatible donor from within the family. If that does not happen, ABO. Of course, for an adolescent, sometimes there is no donor, for example, and the likelihood of getting a cadaver, though small, does remain. And the biggest challenge that we see in adolescents is that, by nature, that's a difficult period in everyone's life. So compliance with medication, taking risks, wanting to try alcohol and so on. Some of these challenges one has to grapple with. So one has to have these meaningful conversations repeatedly with the child and also with the parents and grandparents and siblings to be able to support the family.
Thank you very much, Anupamji. I think a lot of the myths about liver transplant will be removed from conscience of our pediatrician as well as the general public who are suffering from this disease. It was really pleasure to have you on this talk show. Thank you so much for coming.
Thank you so much, Dr. Tuteja, for this privilege and greetings to everyone who's part of the amazing network that you've created. Thank you very much.
I hope this session will be helpful to all our viewers.